Good afternoon. Welcome to the Association of Justice and Treatment Providers 2023 Justice and Treatment Partnerships Workshop Conference. This conference involves 6 plenary sessions. We had the first plenary session at 1 o'clock this afternoon. This is the second plenary session. And what the Association of Justice and Treatment Providers tries to do is to provide a forum for subject matter experts and people with lived experience to share ideas on how we can continue to improve our efforts to optimize successful outcomes in areas where justice and treatment intersect, and also in areas that affect the various determinants of general well-being, the social, economic, and other medical, psychological determinants. And in so doing, as we bring the experts together, they are going to express their opinions. They're going to share their expertise with us as part of our learning processes. And we may not necessarily endorse their views, but we believe that those views are important to allow us all to grow. And today is one of those such learning opportunity. The chair, I'm the conference chair. My name is Justice Barnes, and what I can tell you is that this whole conference was put together by a group of people: Brian Cooper, Eileen McGinty, Megan Oliver, Carol Sinclair, and myself. And the biographies of all of these subject matter experts, as well as the subject matter expert we're going to hear from today, can be found at www.justicetreatment.org, where you get the full biographies of our speakers during the conference and also today. This presentation will be recorded and certainly will be available at the same website in the future. And you are going to hear a topic, the treatment for incarcerated populations, opioid agonist treatment. Kate Johnson is going to be the subject matter expert we're going to hear from. And she'll be introduced by our moderator, who is Norma Nicholson. Norma Nicholson will be doing a presentation of her own in the coming days. And I'm going to introduce Norma, and Norma is going to introduce Kate, and Norma is going to be in charge of the session going forward. What I can say is that Norma is a 4-time published author, speaker, educator, youth and adult mental health advocate. She is a retired registered nurse with a Bachelor of Arts degree in Sociology and Psychology and a Master's of Arts in Adult Education. She is a recognized public speaker. She addresses the needs of vulnerable and at-risk teens and their families. And she has over 30 years of public service experience. She has spent most of her time motivating and mentoring families and youth and efforts to help them transform their mindsets to see the world in positive ways. You can learn more about Norma at www.justicetreatment.org. So having said that, Norma, I will turn this presentation over to you.
Thank you, Justice Barnes, and welcome, Kate. Welcome to all our participants today. Before I introduce you, Kate, I would like to do a land acknowledgement from my home office in Mississauga, Ontario. I am speaking to you today as a settler from my home office in Mississauga, which is the traditional territory of many First Nations, including the Wendat, Haudenosaunee, and the Anishinaabe, and the Mississaugas of the Credit. This land is covered by Treaty 13 with the Mississaugas of the Credit. I wish to pay respects to the many Indigenous people who live and work here today. I acknowledge that many of you, if not all, have faced the pain of racism in your very own ancestral land. So thank you for allowing us to be in this space today, and welcome, Kate. Kate is Director of Clinical Services at the Canadian Addiction Treatment Center. And I'll just share a bit of her bio. Kate spent her early career working in the federal correctional system. From there, she spent time working with youth involved in the criminal justice system, something my heart reaches out for. After seeing the link between traumatic experiences, mental health, and substance use and incarceration, Kate retrained to become an addiction counselor, primarily working in Eastern Ontario. She has broadened the scope of her job by joining the Canadian Addiction Treatment Centers in 2015, and she is now in a leadership role as the director, where she's responsible for clinical services and operations in 74 treatment centers in our province of Ontario. Would you believe that she's actively engaged with over 15,000 patients in a month? Driven by a personal passion for improving access to high quality, cost-effective opioid agonist treatment, particularly in rural communities, Kate is committed to changing the trajectory of opioid fentanyl epidemic in Canada. And this is such great timing, Kate, because there is such a large need to change this trajectory. So before I say you're on, may I just say to our participants, today your questions, please place them in the Q&A, not in the chat. Throughout Kate's presentation, if I see a question that she could answer right away, depending on where she's at, if not, I will be sure to leave some time at the end for questions. And now, Kate, the floor is yours.
Thank you, Norma. Okay, gonna queue up my presentation here. Let's start from the beginning, shall we? Can you guys see my screen?
Yes.
Okay, bear with me here, sorry. Just a few disclosures before we get started. So I sometimes go to conferences and I select sessions that I want to attend based on the title. And sometimes I get there and I'm a little bit disappointed because the presentation doesn't match the title. So I apologize in advance if I've done that to any of you here today, because I really did want to bring something compelling. As Norma mentioned, this is really a topic that's really near and dear to my heart. So let's get started. My hope today is really just to raise awareness around some systemic challenges that I see within the provincial system, and also to help people understand the current toxic drug supply, illicit fentanyl and all of its analogs. I hope to help people have a better understanding of the role of opiate agonist treatment, which I will refer to as OAT, O-A-T, going forward in this presentation, and the importance of the continuity of care for OAT within the justice system, specifically for folks who have been incarcerated provincially, and then also identify some systemic challenges that make retention on OAT really challenging and actually increase the risk of overdose and negative outcomes. So just a little bit about the organization that I work for. So we have 74 opiate agonist treatment centers across Ontario. For those of you that may not know what that is, it's essentially a methadone clinic. We do methadone and buprenorphine, Cadian monotherapy, alcohol use disorder, and some stimulant use disorder. We have 4 inpatient treatment centers. They are private, so only folks with money or good benefit plans can attend them right now, and we are working with the government to try to obtain some OHIP-funded beds. We have 25 specialized addiction treatment pharmacies, and we do have a very robust virtual intensive outpatient treatment program. So altogether, we serve between 14,000 and 15,000 patients every month through our clinics. So this is the challenge that I see on a daily basis across our 74 centers across Ontario. So upon release from incarceration or from court after incarceration, individuals who have opiate use disorder don't often have the support that they need to manage their substance use safely. And this results in increased risk of overdose, particularly in days 4 to 7 post-release, increased emergency department visits, high-risk behaviors like criminality, sex work, injection drug use, you name it, in order to support their substance use. And all of this obviously could lead to increased recidivism. This is just to demonstrate, how this is all over the media and that this is a hot topic for all agencies. It is a public health crisis, and I think anyone that is working in this space understands how critical it is that we start to address some of these issues and break down the silos, I think, that are preventing people from working together. So the overdose crisis is essentially fueled by the toxic drug supply, fentanyl and all of its additives and analogs. The illicit supply of drugs has never been more toxic or more fatal. The graph on the left demonstrates opiate toxicity deaths in Ontario from 2016 to March of 2023. So I did want to point out that the 2023 data on the graph is low, but it does represent just the first 3 months of this fiscal year. And you can see a marked increase in overdoses starting in 2020. And I think we all know that's contributed to the timing of the COVID-19 pandemic and an expansion of fentanyl. The graph on the right demonstrates opioid toxicity deaths and illustrates various fentanyl analogs and then non-fentanyl opioids. So as you can see, this is not a crisis that's going away, and overdose deaths are not necessarily decreasing or going down. So the percentage of total opioid-related poisoning hospitalizations involving fentanyl or fentanyl analogs continues to rise. And this graph that I'm showing here is particularly concerning because if you look at 2023 data, this is higher than the previous years, and it's reflective only of the first 3 months or the first quarter of this year. So hospitalizations are at an all-time high. And that's another reason that I think we all need to have this talk. So of all accidental opioid toxicity deaths so far in 2023, 81% of them involved fentanyl. So that stat right there is essentially why I'm talking mostly about fentanyl in the context of opiate use disorder today. This is just another graphic that demonstrates opioid toxicity deaths. So we've seen an increase, a 2 times increase in the number of opioid toxicity deaths from 2018 to 2021. 85% of them, of substance-related deaths, involved opioids as a direct contributor. 2,547 opioid toxicity deaths in 2021, and 90 of them were caused by non-pharmaceutical opioids. So people are not dying necessarily of prescription opioids like OxyContin, hydromorphone, morphine. It is really based on the illicit fentanyl. And if you move to the graph, the bar graph on the right, the red line demonstrates the dramatic uptick in March of 2020 at the onset of COVID. So again, that was a pivotal moment in this space for folks. A lot of people will say that connection is the opposite of addiction. And in March of 2020, we were all told to go home and isolate and stay as far away as we could from people. And I think that anyone suffering with mental health related issues felt that to be extremely exacerbated. So the timing, as I said, of fentanyl getting stronger, more potent, and more available, and the COVID-19 pandemic was absolutely deadly. Northern parts of Ontario are most at risk. So death rates are similar in rural versus urban residents. So if you look at the stat here on the sort of bottom right, rural illustrates 15 deaths per 100,000 people, which is only one less than the urban centers, which is 16 deaths per 100,000 people. And I think, those of you that are familiar with northern and rural remote locations in Ontario, it's very well known that they have reduced access to services and are generally more marginalized than folks in urban centers. So the resources that may exist, the strained resources that may exist for folks down south and in urban centers just simply aren't available to these folks. People who have been incarcerated are at extreme risk of fatal overdose. And so this slide, I think, is really the crux of what we want to talk about. So this is a study that was done. It was published in 2020, so it's actually old news. I would love to see more recent data on this, but as you guys know, data is very slow to come and be studied and then released. But in this study, 129,152 people who had been incarcerated between 2015 and 2020 died from opioid toxicity. And so there's a lot of data to indicate that people who have been incarcerated are at increased risk for overdose death. And the rate of death is the highest between day 4 and day 7 after release. So total number of deaths within certain periods post-release for exposed groups in this is shown. So 15.6% of all opioid toxicity deaths in Ontario occurred among people who had been incarcerated in the last year. Okay, so I'm going to switch gears a little bit here and talk specifically about fentanyl. So I apologize for anyone if this is old news, but I think it's important to understand why fentanyl is so dangerous. So 1 gram of fentanyl is the equivalent of 2,000 to 4,000 milligrams of morphine or 500 milligrams of methadone. Individuals who have been incarcerated have a greatly reduced tolerance to opioids. And so the reason the risk is so great is people who are released to the community after being incarcerated with their incredibly reduced tolerance to opioids use a very powerful opioid like fentanyl, and overdose is imminent. Other health risks associated with fentanyl use or any substance use really, in terms of injection, we're looking at increased rates of HIV or hepatitis C. You can look, people are at risk for injection related infections. cellulitis, endocarditis, and then also the overdose risk, because when you're injecting any drug, but particularly fentanyl, 100% of the drug hits the bloodstream at once, increasing the risk of overdose. Fentanyl is often smoked by people or snorted, and while that is sometimes less deadly, it is no less dangerous. So obviously adverse effects on lungs, increased risk of respiratory problem, risk of communicable diseases still exists for people that are smoking and sharing things. And of course, the risk of overdose remains. I'm just going to skip this slide. So I want to talk a little bit right now about opioid use disorder specifically, because I do think it is something that is often misunderstood. Drug use in general is often characterized as a moral failing, but opiate use disorder differs from other substance use disorders in the way that the opioids affect the body. So the first thing we need to know about opiate use disorder is that it's chronic and it's relapsing. So this is actually taken from the DSM-5 criteria to diagnose opiate use disorder. And so in order to make that diagnosis, patients or clients need to have at least 2 of the following 10 things that I'm going to talk about right now. And depending on how many of these items that we can check yes to depends on the severity of their opiate use disorder. So mild, moderate, or severe. So how we characterize opiate use disorder is the opioids or the drugs are taken in larger amounts over a longer period of time than was intended. Mm-hmm. It's characterized by a persistent desire and or unsuccessful efforts to cut down or control their opioid use. The person is generally spending a great deal of time in activities necessary to obtain opioids, use opioids, and recover from the effects of opioids. It's usually accompanied by incredible cravings to use opioids. It results often in a failure to fulfill obligations such as work or school or personal matters, parenting. Essentially, home life and relationships are often affected negatively. Persistent or reoccurrent social and interpersonal problems caused or exacerbated by the opioid use. Important social, recreational, and occupational activities are given up or negatively impacted because of opioid use. Recurrent opioid use in situations that are physically hazardous. And continued use despite the knowledge of having a persistent, recurrent physical or psychological problem that is likely caused or exacerbated by opioids. All of this to say, and this is the sort of important part, the last 2 things that people have to demonstrate is tolerance. And we talked about that earlier, how someone's tolerance in the absence of opioids when they're incarcerated is greatly decreased. And tolerance is defined by either or both of the following. A need for a markedly increased amount of opioids to achieve intoxication or the desired effect, and a markedly diminished effect with continued use of the same amount. So that's the withdrawal syndrome that makes opiate use disorder so difficult for folks. And this is why the concept of using opioids being seen as a moral failing or a choice is very, very, very wrong. So withdrawal syndrome is manifested by either of following: a characteristic opioid withdrawal syndrome, or using the same substance or even another substance to relieve or avoid the symptoms of opioid withdrawal. For those of you that may not know exactly what opioid withdrawal looks like, it's like an extremely, extremely bad flu. So people with opioid use disorder who experience opioid withdrawal will feel anxious. They will have nausea and vomiting. They will experience incredible insomnia and a racing heartbeat. They will have abdominal cramping, muscle cramps. They will often call it like bone ache, sweating and cold flashes, restlessness, depression, sometimes paranoia. And this is all accompanied by really intense cravings to use opioids. Depending on what sort of opioids folks are using, particularly if they're using short-acting opioids like fentanyl, these symptoms can occur anywhere from 4 to 12 hours after their last opioid use, and they can last for 4 to 10 days in duration. And this is the part that makes life very difficult for people, and perpetuates this sort of endless cycle of use. So let's talk a little bit now about opiate agonist treatment. So opiate agonist treatment right now is essentially methadone or buprenorphine. Some of you may know buprenorphine by the brand name Suboxone. So both are long-lasting synthetic opioid medications. Tolerance to methadone and buprenorphine does not develop like it does with short-acting opioids, either prescription or illicit. Which is what make them really, really beautiful treatment options, because once a patient is stabilized on an appropriate dose, we don't have to keep titrating the dose up to match their tolerance. They don't develop a tolerance to it. Because they are opioids, they eliminate the painful withdrawal symptoms that people feel in the absence of their short-acting or illicit opioids. And this allows folks to focus on being more productive, whatever that may look like. So it eliminates the cycle of behaviors to obtain drugs, use drugs, and recover from drugs. And ideally, it can help people get back to things like parenting, work or employment, repairing relationships, education, that type of thing. The beauty of methadone and buprenorphine as treatment agents is that they don't provide the narcotic effects like euphoria, or they're not mind-altering like fentanyl or prescription opioids. So at the appropriate dose, the person should be able to fully function with no high or sedation or drowsiness. And the whole goal of methadone and buprenorphine is to focus on optimizing the patient's functionality. We've recently added, anyone working in this space has recently started to add Kedian as an adjunct to methadone. Kedian is slow-release oral morphine. And with the onset of fentanyl and the fact that fentanyl is so potent and powerful, methadone alone as a treatment agent was struggling to be effective. And if you recall the slide I had showed you earlier where we talked about fentanyl comparisons, it often takes up to 500 milligrams of methadone, which is an incredibly high dose, to match the strength of fentanyl. So in recent years, prescribers or addiction medicine specialists have started adding Kedian to methadone as a way to help mitigate the potency of illicit fentanyl. And there's early data to suggest that this is extremely effective in helping to stabilize folks. Retention for patients who are on methadone and Kedian is starting to be very favorable, and it's definitely something that we are going to watch and study. So the way that opiate agonist treatment works is that methadone and buprenorphine both block the effects of other opioids and are meant to consequently discourage opioid misuse. So they occupy the opiate receptor sites for an extended period of time. And the thought is using other opioids essentially becomes pointless because there's no available room left for them in the opiate receptor to be activated. So this blocking effect is most effective once a patient is on a stable dose. When a patient starts methadone or buprenorphine, they're started on a lower dose and then titrated up on a regular basis over days to weeks until they reach a dose that's optimal for them. An optimal dose of methadone or buprenorphine essentially would feel like no withdrawal symptoms. The patient would experience no opioid withdrawal symptoms for 24 to 36 hours. So they could be kept just on their single methadone or buprenorphine dose each day, not experience any withdrawal syndromes, and not need to use other opioids. In the fentanyl era, achieving a stable dose of methadone or buprenorphine is becoming increasingly difficult due to the strength and potency of the toxic drug supply. And so this is causing some challenges within the treatment space. Pros and cons of methadone and buprenorphine. Both can be incredibly effective as treatment agents. It's important to note that most misuse of medications actually occurs by people who are not on a formal OAT program. Neither medication is the full solution. There are lots of psychosocial issues that need to be supported and solved in conjunction with medication-assisted treatment. Buprenorphine has a ceiling effect. And so particularly in the era of illicit fentanyl, it's often not quite strong enough for people who are using large amounts of fentanyl. And we do an annual patient survey every year of our 14 to 15,000 patients, depending on the day. And data from within our patient survey says that 70% of patients who have tried methadone and buprenorphine both prefer methadone. Interesting fact, and is something we're sort of digging into a little bit more. Recent research indicates that there's lower retention for buprenorphine patients versus methadone patients if they use fentanyl, illicit fentanyl, large amounts of fentanyl regularly. And another agent that we need to talk about in the context of this presentation is Sublocade. So Sublocade is an extended release buprenorphine. It's a very long-acting agent that's actually in the form of a depot injection in the tummy. And it can provide very prolonged overdose protection upon release from jail. So let's talk a little bit more about Sublocade. So Sublocade is very widely used now in the correctional setting. And it's got some wonderful benefits. Like I mentioned, it's got long-lasting protection from overdose for folks who are using fentanyl previously, are put on Sublocade, and then requires fewer resources to administer. So having worked in the corrections space, I completely understand why this is a go-to in that space. For those of you that are familiar with that space, if you can picture the daily pill parade of people from their range or their cell down to healthcare, very, very tricky to operationalize, lots of inherent issues with that. With the Sublocade injection, people are good for up to 28 days. And it is very long acting. So in terms of the correctional setting, it's absolutely the perfect agent to use, particularly with resources that are strained and stretched. It's easier for the patient to manage who's receiving treatment. If you're in the community, similar to if you're incarcerated, it removes the daily trip to the clinic or the pharmacy and gives people a lot more freedom and flexibility in their life, which I think is a huge positive. One of the number one complaints about methadone and buprenorphine programs is that it's an incredible commitment for people, particularly in the early days, because it does mean a daily commitment to their clinic or pharmacy. And of course, there can be no diversion with Sublocade. So because I mentioned it's a depot shot into the tummy, it's in there and you can't get it out, and you can't sell it, you can't give it away, you can't share it. So it's got a very, very good safety profile. The challenges, and this is not meant to be critical of Sublocade as an agent or as a treatment option. I think that the trouble comes with how we arrange continuity of care for people who have been incarcerated and are on Sublocade and then are released to the community. So for patients who have perhaps only had one shot or one dose of Sublocade while they are incarcerated, overdose protection may be a little bit more limited or may not last as long. It unrealistically places the onus on the client or the patient to coordinate their own care in the weeks or months after release, with potentially long intervals between appointments. And I know for what I see in our daily work is that often when people are released back to the community and are potentially living in chaos or difficult conditions, it can be very difficult to remember when you need to get to your provider for your next injection. So I think developing a system to help folks remember that and stay on track with that would be really a really important next step. Improved continuity care planning would really help reduce negative outcomes. So this is an example of how Sublocade can go wrong after release. So persons having a short stay in a provincial jail or detention center gets one dose of Sublocade, let's say 3 days before release. Upon release, they're instructed to go to their local provider, who they may or may not know, to get their next injection in about 25 days. Patient or client re-enters the community. Their life is probably full of distractions, challenges, and perhaps triggers that exacerbate their substance use. Very difficult in that sense to make their appointment with their local O provider to receive their next injection, and then they fall off treatment. At some point, opioid withdrawal is going to start, and they're going to be pulled back into their drug of choice. And because of that, more likely to engage in high-risk behaviors. Although fentanyl is pretty cheap and plentiful, you still have to have a way to pay for it. So may have to engage in petty crime, sex work, all kinds of things that are going to produce negative outcomes. And potentially the person overdoses and ends up in an emergency department and is eventually arrested again, and then the cycle continues. So this is the current reality. And I want to talk specifically about two things, which is release planning for people who are released from remand custody. So this is a huge challenge, and I do want to just state clearly that this is not meant to be critical of anyone who may be working in any of our provincial correctional settings. I think these guys are really stretched. Lack of resources. I think anyone working in the healthcare space is facing compassion fatigue, or in the treatment space is facing compassion fatigue. We all know we have an incredibly siloed healthcare system. And for those of us that work in the opioid agonist treatment space, there's a huge lack of consistency among OP providers that make it really, really difficult for healthcare inside these facilities to do good discharge planning. So interruption in care. So clients who don't receive their medication after release are looking at having, if they're not on Sublocade, withdrawal setting in within 36 hours at the latest of being released to the community. Oh, sorry, guys. I need to move this thing. I don't know how to do it. There we go. System navigation is very difficult for people released from remand custody. So oftentimes when you are released from jail, you're just dumped somewhere, and you may not know how to navigate the system, and you may not have a place to land. You may not have any money. You may not have a cell phone. You may not be able to afford a bus to get to your local provider. all kinds of challenges in terms of system navigation for people who are released from jail, and then lack of resources. So I think most folks would face significant financial limitations and may have not adequate access to coverage for treatment medications. The other scenario I just wanted to highlight or talk about is when someone is released from court. So often folks are incarcerated and end up in court and then subsequently are released from court instead of from a provincial jail or detention center. So again, very, very difficult to operationalize. But advanced discharge planning often doesn't happen because it's almost impossible to do. Again, inconsistent OAT access and inconsistent OAT providers across the province. So every OAT clinic has different hours, different policies, different access to physicians and that sort of thing. And bridge scripts are provided inconsistently. So for those of you that may not be familiar with what a bridge script is, a bridge script is literally a prescription for methadone or buprenorphine to bridge a patient's treatment while they're in between the community and jail or jail and the community. And so it's a very simple thing that can be very powerful. And if people are released from jail or court with a bridge script and know that they can go to their local drugstore and get their methadone or buprenorphine, that's one small step that we could all make to ensure that people have good continuity of care for their opioid agonist treatment. So the special challenge for people released from court is that their effects are often left in jail. So people who went into jail perhaps with a wallet, a cell phone, a health card, a bank card, are now walking away from court, probably quite happily, but without any of those things. And system navigation without a health card, without a bank card, without a cell phone can be incredibly, incredibly difficult. And so instead of focusing on how do I get back on treatment or how do I contact my doctor's office, I think folks are preoccupied with how am I going to get my stuff back? And that's a real problem for people. I think in lots of communities, particularly in Southern Ontario, there are wonderful agencies that are in place to help with those things. But that in itself can be a struggle getting to that agency, and those agencies are often stretched and under-resourced as well. So what happens? This is the danger. When people are released without proper continuity of care planning for their methadone, their oral buprenorphine, or their Sublocade, they are more likely to overdose due to reduced opioid tolerance during incarceration. And then because of the unpredictable potency of illicit fentanyl, that is likely also cut with other agents like benzodiazepines or tranquilizers. And so they're also at risk of relapse. So if people live through an opioid overdose or don't experience an overdose, they are most likely to relapse to opioid use because of the withdrawal syndrome that I talked about earlier in our chat. I wanted to share a case study. This is a real person. I changed his name. His name is now Joe. And this is an example of what can happen with poor discharge planning or lack of continuity of care. So just some background on Joe. Joe is a 37-year-old male. Joe has a long-standing history of opiate use disorder and polysubstance use. And in Joe's 37 years, he has had many and frequent incarcerations in the provincial system. Joe self-reports that he supports himself through petty crime and also sells drugs. He has presented to the local emergency department over 30 times in 2023 alone. for opioid toxicity related matters or for drug-induced psychosis. In the spring of this year, he was admitted briefly for drug-induced psychosis and subsequently released. He is currently living in a shelter and faces incredible food insecurity. Last year, he had a traumatic amputation for 2 of his toes due to an accidental gunshot wound and has overdosed self-reportedly over 100 times in the last year. So Joe was incarcerated for several months at a provincial detention center where he was receiving 25 milligrams of methadone every day while he was incarcerated. He was released on November 8th with no discharge planning. So there was no communication to his treatment provider. I want to say this could be on Joe as well. Joe may not have felt like sharing that information. He could have been uncooperative and had no interest in continuity of care once he was released into the community. So that's an important caveat. I want people to understand that this isn't a criticism of this particular detention center. It's a very complex issue. No prescription for methadone was provided in the community for him to access after he was released. And 4 days later, actually I think it was 3 days, November 11th, Joe was taken by EMS to the local emergency department after overdosing on fentanyl. He was revived in the emergency department, and I'm not sure how many of you are familiar with Narcan or naloxone, but once it's used, people are often back in acute opioid withdrawal, which obviously people are very angry about and they're incredibly uncomfortable. So if there's no overdose protocol or if there's no opioid protocol in the hospital, folks will generally leave against medical advice because they're in acute opioid withdrawal and they need to go find opiates to use to feel better. So that's what Joe did. Joe left the hospital and was returned to the hospital by EMS 12 hours later after he was found overdosed, unconscious, naked from the waist down. He required resuscitation, airway protection, multiple Narcan doses, and was subsequently transferred to the ICU. 2 days later, Joe left the hospital against medical advice due to opioid withdrawal that wasn't treated. And Joe still has not presented at his local clinic to resume methadone treatment. So how could we help Joe and all of the Joes that are out there? I think improved discharge planning. So ideally, it would be a systemic overhaul that is standardized. And every patient who is incarcerated and released who is on methadone, buprenorphine, or Sublocade has a very robust discharge planning that includes a bridge prescription in the community for methadone, buprenorphine, a very formal linkage to care that could be done through fax or connection to a local OAT clinic, linking with outreach. So a lot of our marginalized or people that are underhoused are well known to local outreach workers who can potentially find them and support the return to care within the community. Shelter planning is a big one for folks who don't have any fixed address. So helping folks plan on where they're going to spend the night, particularly in the winter months in Ontario. And I think supplying naloxone upon discharge would be an important next step. So while you're overdosing, obviously you cannot administer Narcan to yourself, but often having it on your body would help the first person who comes along revive you and save your life. And I think the other option available to us would be to scale drug treatment courts and help facilitate participation in opiate agonist treatment, among other interventions based on people's stage of change. So again, I don't have the solution. I want to just start the discussion and hope that we can engage all of the stakeholders across the province to think about what the solution to this problem could be. A lot of evidence-based treatment is already integrated into all of our correctional systems, but we have to figure out how to break down the silos and ensure that once people leave, they're leaving in a position of safety for continuity of care. So recommendations. This is, standardize the release process from provincial corrections for individuals with opiate use disorder who are currently receiving opioid agonist treatment while incarcerated is the #1 recommendation. #2, integrate continuity of care planning for opioid agonist treatment into the release process from court, including individuals who are on Sublocade. And consider providing virtual access to holistic wraparound services, including for complex mental health issues. One of the things that I think we can all agree on is that there aren't enough resources or bums in seats in communities to serve this population. And I think the only way that we could reasonably scale it would be through a virtual access, which would include providing folks with technology. Today in our organization, and this isn't meant to be a pitch for my organization because there are lots and lots of opioid agonist treatment providers available in lots of communities, and we all just want the same thing, which I think is better linkage to care for these folks. So access to opiate use treatment is imperative. And scaling regional drug courts by community is another thing that I think could be really, really helpful. I think that not just my organization, and I'm not able to speak on behalf of other providers, but I think anyone would be willing to engage and help in that way if they were tapped or asked to start a conversation about it. One of the things that I think is unique to us is that we do have a very robust footprint. So we do offer same-day access to the program. We have 69 addiction medicine specialists across Ontario. We are almost 80% virtual care, simply because you cannot reach rural, remote communities in person these days, and virtual care is the only way to provide OAT in some communities in the absence of local prescribers.
5 minutes to go.
Okay, thank you. I will just skip to the end. So key takeaways, I'll just summarize again. Lack of integration of substance use disorder or opiate use disorder treatment within the criminal justice system is, I think, hurting people in our communities. Access to OAT needs to be integrated into the release process, both from jail and from court. And we need to consider all virtual and other options in terms of how we can support people. That's it.
Thank you so very much.
Thanks.
Okay.
I just have to stop
There is a question here from someone at Ryerson. Considering the stresses are a major contributing factor to drug use, how do we make sure that clients are stabilized, especially those that are homeless? I think you addressed some of that, but just to walk through, the person, for example, is leaving your services. Is there any way, other than the recommendations that you have made, that is now available to someone who is homeless, has no money, has no connection to a specialist in the community?
It's a great question. Another recommendation that I have for my organization and a call to action for anyone else that's providing treatment in the community. I think in this time, in this landscape, we have to get really creative and start thinking outside of our bricks and mortar locations. So I think we have to think about how we can incorporate outreach and take services to where people are at instead of expecting people to come to our services in that really traditional healthcare model. So I think being able to provide, and that's again the beauty of being able to provide telemedicine or virtual services. You really only need a cell phone or a tablet or a laptop to be able to take a doctor or a healthcare professional to an encampment or a shelter. And then things like delivering the medication so that you can reach folks where they're at, as opposed to expecting them to make the journey to the drugstore or the clinic. I think those are really, really important things that we could all be doing to help bridge that gap, so that when our systemic challenges aren't easily solved, we can go and find people who are interested and make sure that we're taking the things that they need to them. I hope that answered your question.
Thank you. There's also a comment that says, thank you, wonderfully accurate and exactly what has been working to some degree here in St. Thomas. You're right on. More of all this is badly needed by so many of our peers.
Thank you.
I have a question. Having worked in, I don't see any more questions in the Q&A, so I'm taking the privilege of asking 2 short questions. How do clients get referred to the clinics?
That's a good question. Generally speaking, I would say greater than 90% of our patients self-refer. So we get very few referrals from healthcare organizations or agencies. We will get referrals from RAM clinics, rapid access to addiction medicine clinics. And a lot of the time, any referrals that come in are through outreach workers or peer support workers. But the majority of our patients self-refer to the program.
Are you finding that when they're discharged from your program, that there is a specialized physician, for example, who will be willing to write these prescriptions? Because I know, having worked in youth justice, that it was very difficult for me to find the physicians that would write methadone order once the young person is being released to the community. So
Right.
how is that connection made? Because maybe some of these clients go off the rail, as you say, because there's no one willing to follow up or even write a prescription, and they may not have the money to pay.
No, that's a good point. I think that that's part of that siloed issue that we have. A lot of opiate agonist treatment providers or methadone clinics in Ontario are working in silos and aren't part of a network of clinics. So for health human resources working inside jails or detention centers, having to figure out, particularly if there's any sort of turnover, we know there's a huge shortage of healthcare professionals, having to figure out who to tie someone to for continuity of care can be incredibly difficult, I think. And then, like, speaking to the inconsistency, any sort of center could have 1 to 6 clinics available to them as options, but you have to hope they answer the phone or that the doctor's in, and there are lots and lots of challenges in the continuity of care piece, for sure. But I really do feel strongly that no one is sort of waitlisted and is at capacity. I think almost every prescriber in the province, inside my organization and outside, has endless capacity to care for more patients in this space.
A reminder to our participants, if there's a question, greatly appreciate if you place it in the chat, as we're about to wrap up this very interesting discussion. I can share a brief joke while I'm waiting, Kate, because having led a healthcare team in youth justice, it was up to the leader of the team to go and pick up the methadone daily from the pharmacy. And there was one morning when I went with a service officer who drove, and just to make sure safety.
Mhm.
And there was a gentleman waiting in the line. He lives in the community, and he wanted to know if it's because I was a female, why I was getting my dose before him that was standing in line. So you can stand in line, but there's a lot of folks who need to stand in line.
Yeah, that's right. Yeah.
No further question. Can we have a last comment from you, Kate? What would you like to see the future for folks that have drug addictions?
Obviously, stigma and discrimination is a big one for me, for people that use drugs. I think having a greater understanding of the, you know, the drivers of addiction, and having greater empathy for that, and then understanding that if we can start to treat the substance use, because all of the other things like homelessness and poverty are much harder issues to tackle. But if we can start to support people in their substance use, whether it's just using safely or entering treatment, I think that's just an important part of work that impacts everybody. But it starts with removing the stigma and the discrimination against people who use drugs.
Thank you so very much. On behalf of Justice and Treatment Partnership Conference, we're very honored to have had you on today. And thank you for the work you do, and have a great afternoon.
Thank you.
Thanks to all the participants. Hope you're taking away something that you can share with others, and you've also had the opportunity to increase your knowledge. There's a lot of hearts going up for you. Thank you, Kate.
Thank you.
Bye, everyone.
Bye.